I am Janet Linus, ICFRC board member and host for today's program. The Iowa City Foreign Relations Council hosts community programs to address topics of international interest. We thank our members, volunteers, and interns for making these forums possible since 1983, the year that the world's longest and deepest underwater tunnel opened connecting Honshu and Hokkaido, Japan. So that's your trivia for today, yes. As a reminder, we are in a new academic year, and if you have not already renewed your ICFRC membership, you may do so at the registration desk. I want to acknowledge our university and community supporters, the University of Iowa's international programs, the University of Iowa's honors program, the University of Iowa Center for Public Policy, and the Stanley U of I Foundation Support Organization for their financial support. And I thank today's special sponsors, Alan Swanson, Blank and McCune Realtors, Bob and Mary Ross, and Cartha. Also, thank you to City Channel 4 for professionally recording our programs and cablecast on City Channel 4 or 118-2 and the U of I Digital Libraries, Digital Archive, the U of I Libraries Digital Archives. Over 200 ICFRC podcasts can now be found on iTunes. At this time, though, it is my pleasure to introduce Ann Broderick, who will be introducing today's speaker. Thank you.
Thank you, Jen. I get emotional and dry-mouthed introducing my friend, mentor, Dr. Rajagopal, who we fondly call Raj. So I will start with the formal presentation, formal introduction. Dr. Rajagopal is a palliative care physician, but started as an anesthesiologist. He studied palliative care. He studied anesthesiology at the Trivandrum Medical College, and he studied at the Trivandrum Medical College and at the All India Institute of Medical Sciences in Delhi. He has been the key to the formation of Pain and Palliative Care Society in 1993. A decade later, he created Pallium India, a charitable trust that created 2 palliative care centers and established palliative care services around the country of India. He is a 2018 nominee for the Nobel Peace Prize. He's been referred to as the father of palliative care in India. I would say the global father of palliative care myself. He was awarded the Padma Shri honor, one of the highest civilian honors by the government of India in 2018. And he received the Alison Des Forges Award for Extraordinary Activism by the Human Rights Watch in 2014, largely because of his work on cancer pain. He was named as one of the 30 most influential leaders in hospice and palliative care by the American Academy of Hospice and Palliative Medicine. He even has a feature-length film about him, and you're not surprised. They're available if you'd like to buy one. All right. Now, I would like to explain the connection that Dr. Rajagopal has to Iowa City. Since 2009, and I'm just going to do a little bit of fact-checking on the 3rd page of the Daily Iowan today. They did not quite have this correct. India Winterim, a program started by the person we call Iowa Raj, Dr. Rajagopal, who is a geography professor, started a program where he sends undergraduates and other pre-professional students to India in different contexts. Since 2009, we have been going to Pallium India to learn from Dr. Rajagopal how palliative care is done in a low-resource environment. He hosts a group between 12 and 20 students go every single year. This was started with the late Dr. Jo Eland. Some of you may know her as a photographer. Some of you may know her as a nursing professor. About 3 years before she died, she approached me at a mutual friend's retirement party and said, "Ann, would you like to go to India, all expenses paid, and supervise students?" And I said, let me think about that. Yes. All right. So, and now I have been going for 4 years, have invited a College of Nursing professor to join me and a College of Pharmacy. And last year we took 20 students. We're in the middle of our recruitment phase right now for this year. This has been, for me, a return to what's important in palliative care. We get to learn what happens when insurance disappears in healthcare, how to show empathy and compassion, and the privilege of being invited into people's homes and into their lives. And I'd like to say that we also bring back certain important elements to healthcare. We learn to sit down when we talk to patients. We learn to listen. We learn to understand how to creatively treat pain and not always with opioids. And most of all, we learn to believe the patient. Because if we don't, Dr. Raj will be on us to not having believed the patient. So I go back for a booster every year just to make sure that those principles stay with me. It is my pleasure to introduce my friend, my colleague, Dr. Rajagopal, but don't miss the Daily Iowan, page 3.
When we fold our hands and say Namaste, it means I bow to the divine in you. I truly do. This city, which I am visiting for the first time, has given me so much. Joe Eland, who came into our lives 9 years back and who is no more now, has a lot of God in her. So do you, Anne. And so do so many of you. And you, who gave 20 years to India. And Greg, Vijay, I feel so enriched for having known you, and thank you for being my fellow travelers, and I'm very glad to have this opportunity to meet you all. By the way, if you have not noticed, I am speaking in English. Please stop me if you do not follow me, and I'll try to speak slower and repeat it. Palliative care often does not mean the same thing to everybody. I mean, even as it has evolved, even officially, it changed. Between the first definition of World Health Organization and the second, it changed drastically. And that second definition is 16 years old. And it is evolving. Often people connect it with end of life, often with cancer. And I'm going to tell you a story now, a story of palliative care. I think you need a bit of help with the technology. Okay, got it. Thank you. So we run a palliative care service. We directly give patient care only in my hometown in Trivandrum. Elsewhere, we work with local partners. In Trivandrum, we work with volunteers, and that's something that I want to talk to you about the participation of the community. One day I got a personal call from a volunteer asking for help. She knew somebody from the neighborhood who was said to have cancer. It's a 42-year-old woman, a single mother of 2 teenage daughters. She I was told, was having advanced cancer, was having pain and bleeding, and has lost all her documents. Therefore, the cancer hospital would not see her. Could I help? I said, of course, bring her along. So she came. She seemed to be not only in pain and bleeding, but also a nervous wreck. So pain in the lower abdomen. Okay, we are very scientific about it. We use a 0 to 10 scale and measure it and ask for the nature of the pain, and we got some information about the bleeding. But it took one of our social workers to sit beside her and ask, Chechi, Chechi means younger brother, you address any older person as Chechi. You look very worried. Tell me, what is it? I think more than her words, her eyes and her expression must have conveyed to the person that this social worker cared for her as a person. And the true story came out. She did not have cancer. What she had was a pregnancy. And it turned out on further inquiry an incomplete abortion, which was causing the bleeding. So here was a 42-year-old single mother in our rather severe society, which can be very judgmental about single women getting pregnant, the mother of 2 teenage daughters. There were 2 main things that were bothering her. One, of course, she couldn't stand with the thought of facing the teenage daughters and telling them that the mother was pregnant out of shame. The second, she was thinking, what would the life be like for those teenage daughters? Her pregnancy would cast such a shadow in our kind of society. Being an unwed mother is not the same thing in our society as possibly in your country. She would be a social outcast, and the teenage daughters would also be targeted. So she had thought of solutions. The obvious solution for her was to give poison to the 2 kids, the daughters, and to kill herself. But when it actually came to the execution, she couldn't do it. She could have easily killed herself, but she couldn't bear the thought of killing the daughters. And this was the real story. I run a standalone palliative care center. I run a palliative care center. What should I have done? By definition, the World Health Organization says that it is for life-threatening illnesses, and is an incomplete abortion ordinarily a life-threatening illness. The obvious solution was to refer her to another hospital, which of course she couldn't bear the thought of. She had to live in that town. If somebody spots her in the hospital, there would be hell to pay. And most hospitals will not accept somebody without a relative to take responsibility in our country. So there were all these discussions in the team. What can we do? It's not our business to do anything. Even that thought came out. Is it not life-threatening when a mother is contemplating giving poison to her teenage daughters and killing herself? What we did was to go further into it. These occasional dissenting voices came up. We said we will do the needful for her. And to convince 1 or 2 of the colleagues, I had to bring out the Lancet Commission's report of 2017, when a global team of experts had decided that palliative care should focus on all serious health-related suffering. So at least I had that. to argue on behalf of the woman. We got a gynecologist on the phone, a very compassionate person, who after her routine work at 7, which finished at 7 p.m., drove for about half an hour just to come and see her. So she said, "It's okay, I'll help, we'll together look after you. Come to this hospital tomorrow." And the woman said, "I won't. That's within this city. Somebody known to me will see me and my children's life will be finished." And this compassionate gynecologist agreed to do it in the next town. So we got the volunteer to arrange the vehicle, got a volunteer to accompany the woman to the next town, to a hospital where she wouldn't be identified. The gynecologist went across and her incomplete abortion was evacuated and she went back home. I don't know whether everyone in our team and everyone among you agree with what we did. We took it as our work. Suppose the abortion was not incomplete. Suppose it was a threatened abortion. I don't know, many people would have disagreed with what we did, but I think I would have done the same thing. The woman's problem was her problem and serious health-related suffering, because health is not only absence of disease or infirmity. By definition, it's also physical, social, and mental well-being. When I consider the girl's treatment, the young woman's treatment, I should consider that the suffering may belong to all these elements. Her pain and bleeding and the incomplete abortion. Her feeling that I am all alone in this world. Nobody cares. And how will I battle life to bring up my 2 children and give them a life each? Her social issue of a frowning society looking down at her, and her financial position where she had to earn every day to feed the children and to pay her school fee. And her spiritual issue, asking, "God, why did you do this to me? And God, I have sinned. Are you going to punish me? And why am I alive? I wish I were dead." All these are elements of our health-related suffering, and I believe whether it's cancer or HIV or an incomplete abortion, if there is suffering, somebody has to do it. And currently, nobody seems to be doing it except the palliative care stream. Otherwise, it would be compartmentalized. Now we are able to look at organs independently, and we still haven't learned the art or science of putting the organs together and treating somebody as a complete person. Now, it is in this context that I want to bring up the concept of social capital. That woman would not have reached me if that volunteer had not been trained in palliative care, and if she did not know that we might help. She was the most important link in the whole thing. Somebody in the community feeling for somebody who is suffering and deciding to go out of her way to do something about it. Now, the social capital, let us say, is the wealth in the community, particularly the wealth of goodness in the community. Now, in our country, we have more of joy in families than possibly in your country. But we are also getting very civilized. And gradually we are becoming more and more nuclear. Not only that, more and more men are going out in search of wealth. Everybody in Kerala, all men in Kerala have the dream of going to a Gulf country and raking in gold and silver. And people from poorer northern states like Bihar and West Bengal and Jharkhand and Manipur come to Kerala so that they can find daily work and send money for the family. So much so, a very tiny nuclear family exists all alone. And because we are getting more and more civilized, the community becomes more and more disjointed. And the natural support that used to be there in the community in my childhood gradually is disintegrating. When I was a child, I remember that one night my mother got a worsening of asthma. She couldn't breathe and she was gradually turning blue. And in those days, roads were very few. I remember that after somebody from the house shouted for help, in about 5 minutes, a lot of people got together after the middle of the night. And 4 young men came forward, picked her up, put her in an easy chair, and physically carried her. After they had gone for it was a narrow paths. When they were tired, they put her down. 4 other young men were ready behind her to pick her up. And she was taken to a mile away to a car and driven to the hospital. That kind of community is what we are also losing. But that community is becoming more relevant and more important and more essential now. And in the social capital, that is the meso element that we are talking about. The community getting together to support those who need help. Do you know of any community anywhere in the world where there are a few good people are not there? Some people who get some satisfaction out of helping somebody else, they are there, but they do not have an avenue to help. We, I believe, have built that meso element of the social capital to some extent. Let me expand that middle picture and show what it means to human beings. One example is, of course, the woman becoming the pregnant woman's practically family member. But 2 years back on World Palliative Care Day, every World Palliative Care Day, we do an outing for patients and families who are confined to their homes. So on this day, there were about 70 patients and families who got together on a seaside. Around 40 of them were people who were wheelchair bound, mostly paraplegics. Being a paraplegic in your country is not the same as being a paraplegic in my country. There, being a paraplegic means you are confined to a tiny room, to 4 walls, often without even windows, and sometimes with the luxury of a window, and without any opportunity to get out of the home, except sometimes to be carried to a hospital. The homes are not barrier-free, roads are not barrier-free, vehicles are not barrier-free, often even hospitals are not barrier-free. So these people, 40 people, had to be brought. They couldn't just get onto a wheelchair and drive themselves. They had to be physically carried from their home to the road so that they could be put on a vehicle and brought. 40 people meant often 160 people were necessary to bring them, 4 to a patient. We had no problem at all. Students from 2 engineering colleges on that Saturday started from their hostels at about 6 o'clock in the morning. 4 went to one place, picked up a patient, and by about 11 o'clock in the morning, all 70 families were there, including 40 paraplegics. What did it achieve? They made friends, they exchanged mobile numbers when they had mobile phones, and they made friends, their worlds expanded, and when the sun was fading, they got to the seaside. And you see a girl in the second wheelchair from here wearing red and green. She is a paraplegic and does not have normal sensation. And she said, the waves touching my feet was the most beautiful experience that I have had in my whole life. Would that be healthcare? If health is not only absence of disease, but also physical, social, and mental well-being, I would say very definitely and emphatically that is healthcare, and we doctors and nurses could not have done it if the community hadn't engaged as healthcare workers, as volunteers. This is mainly my message. We need to get the community involved if we are to get true healthcare across to people who need it. But this community doesn't get together spontaneously. It's already broken. In condominiums, whether it be here or now back in our cities, those who occupy the next one does not know their neighbor, and if somebody shouts in pain in the middle of the night, the best they can hope for is that someone may get the mobile phone and ring for the police or the fire brigade or somebody. Nothing more is likely to happen today. So this process needs to be facilitated. Initially, we just welcomed volunteers and 2 or 3 people came, and that's how it started. Because the people who started our movement, my colleagues and I, thought that we need to engage the community, and our friends joined us, and that's how we got started. But for that to spread through the society, we needed a process of facilitation. What we usually do is to start with an awareness program. One important thing is, in every community, a facilitator is necessary. Otherwise, they don't get together and they don't see how they can get involved. And another basic requirement is, we in the healthcare profession should be able to welcome them. We are reluctant to. Even if somebody says, come, wait, let us come and help you, we will do your work for you, we are reluctant. Because volunteers are inconvenient. They can ask very inconvenient questions. We are very comfortable now. We can do things in our own paternalistic, autocratic way without being questioned. Once we are prepared to accept them, and once we find the facilitator, the activist in the group, then we talk to them about health issues, about palliative care, about what volunteers can do. We tell them stories of patients who are helped by volunteers and stories of volunteers who feel fulfilled by what they do. Once we get the interested people together, there would always be a few volunteers who say, I want to do this. Often, people are looking for a meaning in their lives. They keep on making money for some time. Sometimes when you are young or sometimes when we are old, we start asking, hey, stop, what's the point? What am I doing? And there, if we offer some people an avenue to be helpful to others, people are often willing. But everybody who says they are willing may not continue. That's also to be expected. People are different. You may have the willingness, but may not have the initiative and tenacity of purpose to continue or to learn new things. But when we get together a few people, we do a training program for them. What we now do is a 3-day program in the classroom, 3 days of classroom sessions. Then for 3 days, they join a palliative care team wherever they work, home visits, usually. Actually joining them. And one of the main things that they learn in the classroom would be some basics of communication, particularly listening. Listening is something that almost every human being, particularly we doctors and nurses, have to learn as a new science. We are not used to it. We are so used to talking and being listened to, is that we have forgotten generally to listen. So that also education is needed for active listening, how to respond to difficult questions, and how to give realistic and not false reassurance. We encourage them to form their own organization in each village. They are not our branches. I think it's very important that they own the organization. We initially encourage them to form informal organizations so that over some time, those who are likely to get weaned off have the opportunity, and those who are committed can form a formal organization. That is something that we help them with. According to our Charitable Societies Registration Act, we encourage them to register an organization. Is there something that I can help with?
Oh, no, nothing. It was making.
Oh, thank you.
Please continue.
Okay. No. I stopped because when a handsome young man is in front of the audience, I have no chance of gaining their attention. Okay. I think you have had a good look. No. So I think that formal an organization is necessary for future accountability. Because even if $10 come in, the organization needs to be accountable for it. And then once it is formalized and registered, we continue to support them. We call ourselves then an umbrella organization with informal links to them usually, and sometimes when they want, with a formal memorandum of understanding. And this facilitation process, I think, is absolutely essential. So what do the volunteers do? In each village or small town, they get together and do a variety of things for the patient. One would be routine. When we go to that place for home visits on every Tuesday, one of them will jump into the car and they will direct us to the patients with whom they are connected. And they act as the link between us and the patients. Very often we are able to visit our patients only once a week or sometimes even once a month. In between, if there is a problem, it is the volunteer who connects with them first and maybe call us and does the needful. The impact of this is tremendous because if somebody has a disability, the impact is very different in our country from yours. Rehabilitation reaches only a tiny minority of the disabled. A paraplegia is a life-threatening disease in our country. They are stuck to their home. And that woman, it is serious health-related suffering. It's not a chronic illness. What she had was a fall and a fracture of the femur. And following that, after she would get the surgery. We are very good at that. Anything expensive we provide in our hospitals, but not rehabilitation. And she would have been at home without physiotherapy, without encouraging exercise, and gradually her limbs would have wasted and she would have become bedridden. And because the volunteer was there, he would go to her every day, encourage her, oh, come on, mom, let us have a try. No, it won't hurt you. I am going to help you. That kind of thing. Encourage her, made her walk, and got her back on the feet. And that volunteer could achieve something so much more than my 9 years of medical education empowered me to do. And because the volunteers are involved, that young woman was the one who took us to that home. The woman in that home had cancer, but what troubled her most was that she would not eat or drink from the morning. Her first meal or first drink would be only in the evening, because she couldn't get to the toilet, not inside the home. She had to walk to the toilet. She couldn't walk by herself, and she would be alone at home. So she would wait for the evening when the grandchildren would come from the school, and then she would drink and eat. And that kind of problem we wouldn't even have known if the volunteer had not led us there, and we could find solutions. And we know that most of those people would not take medicines if I just give prescriptions, because they have no money left. Everything has been finished with the first MRI scan. The family's cow is sold for the second MRI scan, and by the time the surgery or radiation is over, they are in a debt trap. So we buy medicines and dispense them. We take the medicines home, and Vijay and Anne and Greg and all have seen the boot of the home care vehicle forms a mobile pharmacy with supplies. And because the volunteers are involved, and because palliative care is not only for the patient but also the family, and because, strangely, children are also part of the family, they are forgotten. We all love them, but we are very cruel to them. And in my country, children would drop out of school when there is no money in the family. And supporting their education is part of our palliative care. And I never give the least attention to this because I don't have to. Volunteers, a group of volunteers runs it. They now educate around 300 children. And once education support is started, it continues till their education is completed. And we doctors and nurses and pharmacists couldn't have done it ourselves at all, I am sure. And that's why I believe for true healthcare, we need participation of the community. But wait a minute. Am I speaking of my country? Is any of this relevant to your country? Because you have a rehabilitation system. You have insurance services, and you have home visit programs reaching patients in their homes. You don't have so many inadequacies that we have. I don't know your country really. I haven't worked anywhere except in India. So I really don't know. But when I visit your hospices, I see a disease that is as common in your country as in my country, or possibly even more commoner in your country than in my country. That's the disease of loneliness, about which there is no chapter in the textbook of medicine. Loneliness is a horrible, horrendous thing. And I see all these lonely people in your hospices. And I loved that little poem written by somebody whom I don't know. I got it out of a blog spot. Do you think that's a very unusual circumstance, or is that very common? I wonder whether people really need to be so lonely. And you have lonely people in hospices, you have lonely people outside the hospice in their own homes, and maybe connecting people and encouraging people to listen to each other may take away much of the disease of loneliness. But that's what I think. When I look at lonely people anywhere, I think if only the community were involved, like you do, if there was somebody to sing to them for half an hour a day, what a difference it would make to their lives. Not only giving the company, but getting the feeling that, oh, finally somebody really cares. I am a human being now, because somebody cares for me. And that I think is precious anywhere. I'll remind you, but that it needs a persistent facilitator. To remind you, it needs ownership by the community, awareness programs about what true health is and what volunteers can do. Starting as an informal organization from our experience is no law. Collaboration with a palliative care team so that physical problems also can be taken care of. And identifying a few needy people and getting started. Getting something done and then learning in the process, and then expanding and forming formal organizations in communities. I see that it's happening in some, they call them compassionate communities. A movement has started in Canada and is at least slowly growing. I hear the same thing happening in Australia. So even in affluent countries, at least some people are finding it useful. The social capital has its negatives. There are threats. One is that, as I said, we may not find the community involvement convenient. Hospitals can think of it does. Do you want me to give a few excuses not to do it? The medico-legal problems. Transmission of infections. How will we know? Suppose they come and infect our patients with low immunity. These people will make the hospital dirty. Any number of objections can be brought up. But then, if it has to be done, we have to find a way around the objections. And of course, there are other problems also. The excellent paper on social capital that I read, written from somebody in USA, talks about vested interests coming forth. It's inevitable, and the organization formed and the community group is very successful. And then there are the power struggles. We do-gooders can be very nasty at times when it comes to power struggles. And maybe sometimes religious influences can have negative influence. Sometimes other political influences can come forth, because if it is seen as a popular movement, it's happening in my state, then political parties also want to be part of it. And what would their motive be? So we'll be cautious about some potential threats also. But that's again not a reason for not doing it. That woman was smiling about a week before she died. And that's what it's all about. Thank you very much for giving me a patient listening.
So our first Kerala is a more advanced state than others in India in terms of literacy, education, healthcare. Does your model work equally well in India's other states?
Not yet. But it's happening. It's happening in one of the poorest states with very little literacy. When I started in Calicut and then moved to Kochi, another city, everybody said it will not work in Kochi. Kochi is different. And when we moved to Trivandrum, I heard the same thing, but it worked there. And we are now trying to get people to accept this, some kind of community involvement in other places. I have seen it happening beautifully in some villages with high HIV population in Karnataka, another state. But now it is steadily growing in a northeastern state of Assam, as far away from us as possible. And the local community and a regiment of armed forces giving their spare time are doing this, and the movement is growing. It has not been successful. I cannot say that we have proved that it works elsewhere, but I have reason to say that I think it's growing and is going to be successful.
Another question is, can you tell us about your stay in the United States and how long you're going to be here?
About my stay, I am absolutely enjoying it. I like being pampered by Anne Broderick. And it has been a sheer pleasure. I am leaving Iowa tomorrow. I am going to 2 or 3 states also, cities also. I am going to Pittsburgh and then to Memphis, Indianapolis and then Memphis. And then I have a son and family living in California in San Jose. So I'll have 2 days of very intense work with the grandchildren. And I'll head back out of USA at the end of the month. But thank you for asking.
I think that's all the questions we have. So, oops, sorry. Can you talk briefly about the U.S. opioid policy's impact on India?
Not only India, on the whole world. Anything that happens in USA becomes known, obviously. It's very unfortunate that a certain growth in access to pain relief, to a large extent initiated by one group in USA, Mr. David Joranson and his Pain and Policy Studies group in Madison, Wisconsin, was one of the biggest factors in improving opioid access in my country and in several other countries, because we did not know this business of policy analysis. He and his team helped us to analyze the laws, identify the obstacles, barriers, and they could help us to overcome them. Unfortunately, following that initial phase in the 90s, then pain management became so successful in USA that I think it became crazy and went out of all control. And somehow, I wouldn't know, but I strongly suspect that the over-enthusiastic industry talking about the non-existent total safety of opioids resulted in the current crisis to some extent. This morning I was with a group of global health students, and one of them said after a tooth extraction, a prescription for rather strong opioids is given for a period of 3 weeks in this country. That kind of irrational prescription happened, and it was, I suppose, asking for trouble. What David Joranson and his team used to preach was the principle of balance. Remembering that we have a duty to make opioids available for pain relief, just as we have a duty to make sure that it is not abused. And that is what was possibly forgotten. The current crisis is said to a major extent not because of prescription opioids, that's what I learned during the last few days. It is because of illegal opioids coming into the country, but certainly prescription opioids seem to be contributing to it. And what is the impact on India? So we got our law changed and made it more humane and compassionate. But its implementation has to be done by 29 of India's individual states. Unlike in your country, in many countries like mine, developing countries, a law doesn't get automatically implemented. It's more comfortable to go on doing the way we used to. So that needs a catalytic action. Now when I go to a bureaucrat or to a legislator, they would ask, yes, but what about addiction? And if I try to explain, they may say, but more than 30,000 people die in USA every year because of this. Do you want that to happen in this country? And some people would say, yes, I understand, one needs to be compassionate to people in pain, but I do not want my grandchildren to become addicts. So that's the impact, not an official change in the policy, but the unseen influence of the news getting to people. it is something to be overcome. It's a reality that we have to live with. We have to continue our advocacy and continue to advocate for that balanced approach. Thank you.
I think this next question goes well with that. And the question is, to what extent does your practice integrate traditional medicine?
I must admit, very little. The three systems of medicine, two other systems of medicine that are popular in my country are Ayurveda and homeopathy. Both are practiced very widely. Ayurveda is a traditional Indian system of medicine. It is fairly expensive, whereas homeopathy is inexpensive and generally believed to be safe, so a lot of people go for that. Unfortunately, they all work on totally independent principles. For the same disease, in the science that I have learned, there is a certain way of treating that disease. In Ayurveda, it is not the disease that's being treated. People are classified into three different constitutional types. The same problem will be treated very differently in the three constitutional types. It's almost impossible for us to reconcile the two fundamental basic principles and have one integrated system of medicine. It has to happen, it will happen, but that will be after such a lot of research. More meaningful research in Ayurveda happens in the UK rather than in my own country. It's progressing slowly. At the moment, we have no way of combining both. So what eventually happens is, we found that 54% of our patients have been taking some alternate form of treatment. Most of them either Ayurveda or homeopathy. So they ask, can we continue it? What I say is, go to your Ayurvedic doctor and ask them. So long as they don't ask you to stop this painkiller or this medicine, it's fine with us. I don't know if it's really fine, but we let them. Some rather hardcore homeopaths would not permit any modern medicines. According to their theory, all these medicines need to be washed out over a 2-week period. Then only the other medicine will be effective. So working together, sometimes it's difficult, but integration, I think, is something many away after a lot of research away.
This one we should have asked at the beginning. How do we become more effective listeners?
Okay. What I did was to look at myself in the mirror, though that's a painful thing to do, and tell myself, look, you have 2 ears and 1 tongue. But it needed practice. It was palliative medicine that taught me to listen. And in our clinic, as Anne might have noticed, in the outpatient clinic, if the doctor is sitting on this side, on the opposite wall, there is a sign just reminding people to listen. I think this is very important, and the realization that everybody has a story, and unless that comes out, we are never able to give, leave alone psychological and social and spiritual support, even physical support properly. So that listening becomes vitally important, and once we realize that, it becomes a habit. It takes some time because we doctors are used to talking a lot and ordering people and being autocratic. And studies have shown that on an average, a doctor interrupts a patient within 7 to 11 seconds after the patient has started talking. So that realization and the need to understanding it, and some schooling on the art of active listening. Listening is not to be passive, it is to be engaging the person with the eye, maybe with nods, and maybe with prompts. Sometimes listening to what is said, but equally important or sometimes more important, listening to what is not said. The facial expression, what is shown in the eyes. Yes, you said you're okay, but you seem to be... Any problem? Is there something that you would like to tell me? And that kind of prompting becomes necessary. But once you start listening, you are at danger of getting addicted. It really opens a world up. Every one of you, even young people, have a story in you that you have never had a chance to share. How many of you have had the luxury of telling somebody the story of your life? The moment you start, after the first 5 seconds, your grandchild stops, oh grandma, not those stories again. We never get to that, and I can't pronounce his name properly. Anatoly Broyard, the former editor of New York Times, he, after he got cancer, wrote a series of things, many of which we may not agree. But one of the things that I can't quote it offhand is he saying that when we talk to people who are getting closer on death, and when you listen to them, just listen to them, and they will share those stories bordering on the sublime, and they will teach you so many things. The article is titled, Doctor, Listen to Me. And that's the title of the article, which you can find on Google. And I believe that is so totally true. Most of my most precious education came from listening to my patients and families. Thank you for the question.
And I think we would like to go on, but unfortunately our time has run out. So we're going to conclude our program, but please join me in giving a big thank you to Dr. Raj, who And I also want to thank our sponsors, the University of Iowa's International Programs, the University of Iowa's Honors Program, the University of Iowa Public Policy Center, and the Stanley U of I Foundation Support Organization for their generous support. And we also thank today's sponsors, special sponsors, Alan Swanson, Blank and McCune Realtors, Bob and Mary Ross, and Cartha. And we thank City Channel 4 for making our programs available to viewing audiences. Dr. Rajagopal, as a small token of our appreciation, we'd like you to come forward, and we are presenting you with the highly coveted Foreign Relations Council mug. So we hope you will take that and enjoy it. Thank you so much. Great. Very good. So, at this time, we are adjourned. Thank you.